Oh, okay. Hello, good evening. Good evening. Oh, I feel so powerful. So we have a fabulously enthusiastic but large crowd tonight. So if you have a seat next to you, if you don't mind scooting in so we can start filling on the sides, or if you see, and we have some up here, or if you see that you are in an empty seat, let us know so we can place somebody. But everybody get friendly. We also, if you are also uncomfortable with how many people are in the room, we do have overflow seating as well. And come see me if you're interested. Thank you.
Well, good evening, everyone, and it is so wonderful to see you all tonight. I'm Sandy Treadway, the librarian of Virginia, and I can't tell you how excited we are to have our speaker tonight and to have all of you with us. I know you're here because you know you're going to hear a phenomenal talk about a critically important topic that sadly today affects virtually every family in America. I see many friends and supporters of the library in the audience, and I want to thank you all for coming out tonight and for your ongoing support for everything we do. I also see a lot of new faces in our audience, and I hope if this is your first time visiting the Library of Virginia, you will come back again and often. And on your way out tonight, if you didn't have time coming in at our check-in table or in the library shop, you'll find our magazine, you'll find our calendar of events, and you'll find information about how you can get involved and engaged with the work that we do. And please do stop by the shop tonight because copies of the book that you're going to be hearing about are available for sale there. I'm also delighted this evening that in our audience is Carole Weinstein. Tonight's program is one of our 2022 series in the Carole Weinstein Virginia Author Series, and we are so thrilled. We're grateful to Carole for her outstanding generosity that makes this series possible and for her faithful attendance at every single one of these events. Carole was absolutely thrilled when she learned that we had secured Beth Macy for tonight's program, especially since this is very early in her book tour. So we and you are very, very fortunate. So when Carole told me she would be here tonight, I was thrilled and delighted that she would like to introduce Beth Macy to you this evening. So Carole, please come on up and we'll get the program started.
Want to make sure you can hear me back there. Yes, good. Thank you. 4 years ago, almost to the day, Beth was here with her breakout book. It wasn't her first, but it was titled Dope Sick. I'm sure you remember it, and you've probably heard a lot more about it since then. But at that time, we had the same overflow audience. And I was personally surprised because I didn't think people were ready to talk openly about addiction. And I can remember I said, I didn't ask for raised hands, but I said, I wonder if many of you, like me, have a member in your family who is addicted to something. And no, what hand raised, but there was nodding. And I could feel, this sort of general acceptance that this was something they were ready to talk about and ready to hear about. 4 years ago, we were a different society, of course, and we were a little still, if not ashamed, a little embarrassed to talk openly about family members who were addicted. That has really changed, thanks to Beth Macy. And society has thankfully and hopefully also opened up with a more permissible, accepting attitude. I remember when Beth first spoke, and I was so ignorant. I honestly thought Purdue had something to do with chickens. Now, I said it that night, and I admitted it, and I thought, and when I saw the movie, I could see that I wasn't the only one who misunderstood that. But we were so proud that she, our Beth Macy from Roanoke, from our Roanoke, she was the person with the slingshot who, with her verbal rock, slayed Goliath, or we could say Goliath, the family, the Sackler family. And no one realized at that time, until maybe they saw the movie, that the Sacklers were promoting this drug as a getting people hooked on this drug, because it was not an addictive forming kind of pain medicine, which was so not true, as we now know. And it did hook people who had never been hooked before, people who were experiencing pain in all kinds of ways, and in the mines, in MINE, mines in West Virginia, and Virginia especially. I have been so concerned ever since the Dope Sick book came out that I reached out to find out where in our community I could support some group, some organization that had a sort of holistic view of treating addiction. And I'll tell you afterwards, you can come up to me and ask me about that. I also, because of this book, have my own little pilot program that I'm not telling anybody about, especially my husband. But I'll tell you about that as well, too. But I am really honored to introduce Beth, who is going to tell us more of what we can do to be active participants in our community. And so, Beth, your turn. Thank you.
Wow, what a great turnout. I'm really honored and so grateful to Carole and to the library. The Librarian, that's actually her title, The Librarian of Virginia, Sandy Treadway. This is now the fourth time speaking about my books here. Are you hearing a little feedback? No? Okay. And I'm just thrilled to be here. I was here in 2018, and I always start my talks about the overdose crisis. Back then, we were still calling it the heroin crisis. Now we call it the overdose crisis. I'll explain later, if I remember. And I would say last year we lost 72,000 people, and every one of them a tragedy. Not just those folks, but their friends and family members. And that didn't even count the people we lost to addiction-related suicide, hepatitis C, HIV, endocarditis. So we know it's a huge undercount. Now I say we have lost a record 108,000 people, Americans, to overdose deaths in the past year, and every one of them feel a tragedy. So Dopesick was a national look at the opioid epidemic as I witnessed it landing in 3 different Virginia communities. I've long been a reporter in Roanoke. All of my books have grown out of reporting that I began at the Roanoke Times, where I worked for 25 years. And I sort of saw these 3 communities, beginning with the coal fields of Western Virginia, as a microcosm for the rest of the nation. Although we know that, as Carole just said, that Purdue did target coal mining areas in places like Lee County, where the Hulu show was largely set. Can I just have a show of hands of how many people have seen the show? Wow. And how many people in the room were actually participants in the show, extras or crew? Wow. Oh, that makes me so happy. Off the record, can you go off the record with 350 people? I fought like hell to get that show made in Virginia. I really did. As Danny Strong, the creator, was flying back from LA to do the trip where he decided where he wanted the show to be made, he was looking at Virginia and North Carolina, and I gave this impassioned, I might have gotten a little tearful, speech about how this started in Western Virginia, and Western Virginia deserved, if there was any benefit to get out of it, we deserve to have it. And boy, he came and looked at Virginia, and there was no turning back. He's like, North Carolina's fine. I like Virginia. It's beautiful. It's so beautiful. And then we had the little town of Clifton Forge that sort of stood in and was near enough that the cast and crew. But I just want to say to the people that worked on this show that all the cast members and everybody affiliated it they love Richmond, first of all, and they loved the people from here that worked on the show. I mean, Caitlin Deaver, who played Betsy the coal miner, will talk about, there was a crew member who was in recovery on set, and she's the character that you really go through the whole addiction journey with. And this person would give her notes after every scene, and it was really invaluable. Okay, so I'm getting off topic. I got excited when you all had watched the show. So if Dopesick was about the origins of the crisis and how people were falling through the cracks, Raising Lazarus is about the solution. I initially, in my proposal, I called it The Fix. And I'll tell you why we changed the name, if I remember, later. So I'll talk a teeny bit about Dopesick, but mostly I'll talk about Raising Lazarus and why I wrote it. When I finished Dopesick, I was like, I can't do this anymore. This is too hard. See my niece Chloe, she'll tell you. I was a little bit of a wreck. And I was like, I'm never writing about this again. Can't do it. My husband said, you should write a cookbook. Which my friend Connie knows, I can throw down some food. And I used to write about food. And then as I started going out talking about Dopesick, I started hearing about really good things. And I was like, nobody else was telling these stories. And these were like kind of outlier stories. And I was really excited to find these stories. And there were stories of heroes and innovators and people that were busting these barriers that made me so mad when I was working on Dopesick. And I thought, I think I can do it if I do it this way. As Mr. Rogers said, find the helpers. And so that's what I did. Now, I'll talk a little bit and then we'll go to questions like 45 minutes in. And where's Tom? Okay, Chris, you'll tell me when I've talked for 45 minutes and I should go to questions. Okay, I got a plant in the second row. I don't really like numbers. It's not my jam, but these are the numbers that really kind of made the hair stand up on the back of my neck and really made me understand what kind of trouble we were in as a nation. So I already said we'd lost a record 108,000 people to overdose. And every time they tally it up every couple months, it goes up. They'll say now, 2 months later, in the past 12 months, we have lost, it'll be 111 probably by the next time we hear about it. 1 million Americans have died of drug overdose since OxyContin was launched, and that number is predicted to double by 2030, just 8 years. We have north of 7 million people estimated to have OUD or opioid use disorder, and that's a figure from just June, which I don't know how they were counting it before, but that ends up being 4 times what we previously thought. Addiction is a chronic relapsing disease. It takes 4 to 5 treatment episodes. This is for somebody with substance use disorder, so all, not just OUDs, but SUDs, alcoholism, etc. 4 to 5 treatment attempts over an average of 8 years to get just 1 year of sobriety. And if it's opioids, it's 2 to 3 years longer, because those folks largely have gotten so low in terms of their abilities, and many of them unhoused, doing sex work in order not to be dope sick, which is this excruciating withdrawal that people will give up their families for. They will, they're just really struggling. And as someone early on in the last book said, at the end of your journey, you're not doing it to get high. You're just doing it not to be dope sick. So the treatment gap, when I first started working on this book, was 90%. That was 2019. And that means that only 10% of people with OUD had been able to access evidence-based care. We've spent a lot of money on it, and it's barely budged. It's 87%. That is hot off the presses. That's pretty accurate. So 13% success rate of reaching people with OUD. That is a big fat F in my mind. That's abysmal. We know how to treat this. We're just not acting with the will that's necessary to turn it back. Most treatment facilities still don't offer the life-saving medicines, that is buprenorphine or Suboxone or methadone, which CDC, NIDA, that's National Institutes of Drug Abuse, and the World Health Org all believe are the gold standard of care. Oh, I see a typo. And 80% of people don't need inpatient care. I think that's because of shows like Intervention and all this, that's become like, oh, that's the thing to do. And a lot of parents think, oh, if we remortgage our house and send our loved one to Nebraska or wherever, some faraway abstinence-only rehab, which isn't what the science says works best for OUD, then certainly it must be good, because look, we're paying all this money for it. And it's just really a terrible situation, and a lot of families are taken advantage of. There are some good ones for sure, including some good ones right here. Every dollar spent on treatment can save 12 or more on reduced criminal justice and healthcare costs, which is more important now. And this is really how we pitched this book. We knew it would come out in 22, right as the opioid settlement dollars are beginning to flow down to communities. My fear is that it's going to go to the same old things that aren't working. Drug war modalities, incarceration first, abstinence-only programs for OUD, when we know that simply for the majority of folks is going to lead to overdose death. So what I say is everyone experiences addiction differently. People should have the choice of what kind of treatment they want. But we know that the access is just so limited with that 87% treatment gap. So at the end of Dope Sick, the reason I was so bereft was that I had been following this young woman from Roanoke named Tess Henry. I'll just talk briefly about her. I mostly want to outline kind of the barriers and then the new innovations that I've found that would have helped her. Because the first time I interviewed her, it was 2015, and she told me how she had gotten overprescribed opioids at an urgent care center. 2 30-day prescriptions for opioids for a case of bronchitis. Yes. fact check, this is the deal. And at the end of the 30 days, she put her symptoms into Google and she realized she was addicted, and then began her journey. When the pills got hard to get, she went to heroin. I mean, this is somebody whose dad is a surgeon, her mom is a hospital nurse. They had a vacation home growing up. And she had an older sister with alcohol use disorder who really lived by this idea that abstinence was the only way. And abstinence wasn't the only way for Tess. She just couldn't do it. Whenever she lost access to her MAT, her medication-assisted treatment, she would relapse, and she would be homeless on the streets, and she would be doing sex work. She would be middlemaning, which is dealing drugs in order to use. And, she lost custody of her son. And then kind of finally, as a last-ditch effort, her grandfather, who was a retired IBM accountant in his 80s, said, let's try one more thing. And they sent her out to another abstinence-only facility in Las Vegas. So when she bombed out of that, which she did about 20 days later, she then was homeless on the streets of Las Vegas. And the reason I wrote this book is because the first time I interviewed her, Tess said, we need urgent care for the addicted, after she told me about being overprescribed at an urgent care center. And I didn't know what that looked like, and she didn't know what that looked like. But she knew what it wasn't, which was every time she tried to get on her buprenorphine, there was a 3-week waiting list. When she finally found a doctor that would take her, it was in Blacksburg, 45 minutes away. It cost $500 the first visit and then $100 a week after that. She didn't have that kind of money. And there were no needle exchanges in town then. The time she went to the emergency rooms, multiple times for abscesses and overdoses, all they did was treat her immediate illness, but never treated her addiction. And so what is urgent care for the addicted? That's the story that once I started seeing, I would be like, oh, this must have been, this is what she needed. So I really wrote this book. I dedicated the book to our Uncle Frosty, who passed away, a year ago. He was my journalism mentor and hero and favorite relative and all that. Don't tell the others. And he was always encouraging me to go forward. And so dedicate the book to him. But I wrote the book for Tess and trying to answer. This is her mother on the right, by the way, Patricia. She's raising Tess's now 7-year-old son. So I've already talked a little bit about it. We need more access to MOUD, that's medicines for opioid use disorder, buprenorphine, Suboxone, methadone. I said there was a 3-week waiting list in Roanoke. And I mentioned the ER that when I would talk to the ER director, the ED director of all of Carilion Health System, which is the largest employer in the western half of the state, he would say, that's just treating a drug addiction with another drug. That's not within our purview. He said that in 2017. In 2019, he got all his doctors waivered in 1 week. 24/7 buprenorphine. They hook you up with a peer counselor and any peer recovery specialist in the room. You're an angel. And that person will work with you if you OD and you end up at a Carilion hospital now. And then you have a treatment, you have an appointment with their outpatient clinic a few days later. And I said, Dr. Burton, what happened? You totally changed your mind. I thought it wasn't in your purview. And he said, well, we read your book. And then we did our own research and we said, how can we not be doing this? And in the first month, he had 37 people connected to care for the first time in their lives. And I said, Dr. Burton, that's amazing. You must feel so good. That's 37 lives that you've potentially saved. What's that feel like? And he said, I feel like doing mental cartwheels every day. And you could hear his voice. like we did a podcast called Finding Tess. Her mother and I went to try to find out what had happened to her in the last weeks and months of her life. And I had the recording from 17. I had him again. And just like the difference, like when people finally start to see what's really going on out there and that they actually can help and that these folks aren't just criminals and moral failures, but rather they're human beings with a treatable medical condition. And then they start to see success and they get so excited. And so that's why I wanted to tell this book. So we still have, so we have a lot more access to MOUD in Roanoke. And I know elsewhere in the nation, but we still have 8% of doctors that have bothered to get waivered. The DEA makes you get, and President Biden and the drug czar and SAMHSA could change this if they wanted to. And I tell them that at the end of the book. But only 8% of doctors have bothered to get waivered. And a lot of even those that get waivered don't want to treat addicted folks because they're difficult patients and we don't want people like that in our waiting room. Well, guess what? I have a chapter that quotes a Harvard doctor in 1926, and he says, an addiction doctor told me this quote like 4 or 5 years ago. It's from 1926, and it says, "The secret to patient care is to care for the patient." And so when I go out and tell doctors, when I go out and talk to doctors, when I first started doing it was right after Tess died, and I had this locket, I would hold this picture of her, and my voice would quake, and I would say, like, "I know not all of you took a free trip to Arizona or California to become paid spokesman for Purdue, but you participated in the system that did. And I know it's more than just Purdue, it's the regulators that enable them and the revolving door. And some bad doctors, yes. And but I'll say you participated in it and you ought to participate in the solutions." And the first time I said that to a big room, it was at the new medical school in Roanoke, and it was crickets. And he said anything. And then Dr. Burton did his magic. So that was cool. So I met Nikki King. She's from Eastern Kentucky. Letcher County is one of the epicenters of where Purdue first targeted with their false narrative about their miracle drug was safe. And Nikki had to run away to go to college. She now has a PhD. She's only 30. But the cool thing about Nikki is she is on fire about this issue. She wants to help, and she's absolutely fearless. She worked her way up to head at a nonprofit hospital in rural Batesville, Indiana. She headed mental health and addiction treatment. And I have this bit about her in the book. She goes all holler when things aren't going her way. She's just so far ahead of everybody else in the room, and you have to keep up with her, and it's really, really hard to take notes. So I always record when I interview Nikki. But she figured out in Batesville, Indiana, where the community decided that their number one problem was the opioid crisis, how to do treatment. And what they did was when someone came out of a jail or prison in that community, Nikki created this program where they would bathe folks in with social workers and peers. They had intensive outpatient treatment. They got them hooked up with Medicaid, so they got their BUP. If they wanted to be on BUP, they got them jobs. They got them food connected to food pantries. They got help with ACEs scores with the kids in foster care. I mean, it was incredible. In the first 18 months, there were 0 overdose. I mean, this is peer reviewed. She did this for her PhD. But she told her boss, who was running a nonprofit rural hospital, they're closing right and left. She said, "I can get this program cost neutral in 6 months," because she was going to bill Medicaid. And what they did was they created this team. It's kind of like drug court, but it's not as rigid. And when somebody would relapse or come up with a dirty drug screen, the social workers would make decisions about whether they went back to jail or not. The answer is not to put them in jail, it's to increase their treatment. And they started to see success. And people who had been in and out of jail their whole adult lives were getting sober for the first time. And it was really amazing. The only problem was that when they sent their first Medicaid bill in, for that cost neutral thing, they said, the bean counters in Indianapolis said, we can't reimburse this because you're not in a medical facility. And she said, that's why it works, because we're not in a medical facility, because we all know each other. They were running it out of a conference room in this old big courthouse in one of those little, kind of idyllic town squares in a small town. And the probation guy, who was very skeptical of this, because jail is like, it's the hammer, the nail thing. Like, that's what they do. That's what they've been educated, inculcated. And we all have, honestly, in drug war thinking. But they started to get excited when they saw their ODs were going down and people were getting better. But then the bean counters came in and they're like, no, you can't do this. And Nikki, as one does when one is 28 and super passionate about her work, burst into tears. And she's got this really thick accent. She's like, y'all, I have no more rabbits to pull out of my sleeve. And then she goes, what if I buy the part of the courthouse? So for $25 a year, she bought part of the courthouse. They walled off a room in a conference room they were already using. And they called it, the name of the hospital, Ripley County Courthouse, Suite A. Because they thought that sounded better than room 1. And the probation head, who had been kind of this super uptight, doesn't want to get in trouble with the judges, like that, like kind of Barney Fife-ish. I didn't say that on the record. He put this applique above the door and it said, make today amazing. And this is not somebody who would have ever thought a person with SUD had a right to an amazing day. Now, when COVID happened, they did start to have some overdose deaths. But I think that 18-month was really amazing. And it was the thinking that changed the practice. So that would have helped Tess and would help the 7 million people we talked about at the beginning. And I love this quote. I did an article for The Atlantic about Nikki. And this is her psychiatrist. Now, before Nikki, there were no psychiatrists in the whole entire county. And she asked around, she said, who's the best psychiatrist? And they said, this guy out of Indianapolis, his name's Dr. Dahl. She called him up. He doesn't want to go to Batesville, Indiana. He's got a thriving, super busy practice in Indy. She took him lunch. He didn't have time to meet with her. And then she arranged for him to be a speaker at an addictions conference and her to sit at the same table at lunch. And she wore him down. And when I interviewed Dr. Dahl, he said, you just have to work in mental health to understand that what she's done just doesn't exist anywhere else. So it's that warrior personality that, this is somebody who grew up surrounded by some of her first memories or of her friends' parents overdosing at birthday parties. And she believes that she designed a program that could be replicable in any state that with a Medicaid expansion. That's the question, isn't it? Do we want to make that program replicable? It's not even that expensive. It is what I would call low tech and high touch. This isn't a problem Google's going to fix. So the next part of my journey was at the time, Virginia passed needle exchange. I forget what year that was, but the first version of the law, I think it was 17. Correct me if I'm wrong. Anybody that remember? The first version of the law said the city council has to approve it and the police chief has to approve it. And the city council in Roanoke was fine with approving it. The police chief said, if you're going to open a needle exchange, you might as well go to the elementary school playground and give out marijuana cigarettes. That's an exact quote. He told the Roanoke Times that. So what we know about needle exchanges is that people who visit them are 5 times more likely to eventually enter treatment. They're 3 times more likely than those who don't. to stop using drugs altogether. It's not just clean needles, which is great because clean needles prevents the spread of disease, hepatitis C, HIV. But it's this connection, this little threads of trust. And the first man that really explained it to me was running a treatment program in Jamestown, New York, or Johnstown, New York. And he said, in the 90s, I was a heroin user in New York City. I went into a needle exchange, and the person at the front desk said, "How can I help you?" And he said, "I'm hungry." And she gave me a sandwich. And that sandwich was the beginning. Eventually, he got sober, not right away. And eventually, he went back to school, got his family, got his kids back, and he has a master's degree and he runs their treatment center. So it's this idea of any positive change as a person defines it for himself or herself is our definition of recovery. That's from the father of harm reduction, Dan Bigg, who started out passing out needles out of the trunk of his car in the 80s in response to HIV/AIDS. And he's very much still people love this guy. So Roanoke, finally, we get a new police chief. We finally get it open. And I go there, and it's run by this guy, Lawson. It's now run by somebody else because it's really, really hard work, and Lawson could only handle it for a couple of years. It's really hard work. The peer back there is nodding her head because this is the hardest work that a person can do. And the first time I go there, I literally burst into tears because I was like, this is urgent care for the addicted. It was such a vibe that Tess would have loved. It was all kinds of people, from people wearing Trump hats to Grateful Dead shirts. People brought their dogs. There's a clothes closet in the back, which, wink, wink, if I'm going to the clothes closet, maybe I'm going to go use drugs and you should check on me, make sure I'm okay. You could get needles. You could get safe use supplies. You get food. You can apply for a job. You can apply for Medicaid. It's exactly what Tess wished for. And if we're going to start to turn this crisis back and to reduce our deaths of despair, we've got to do the counterintuitive thing, which a lot of folks will say who haven't studied it and don't know the data I just gave you will say, well, you're just enabling. But no, because of this idea that people are so driven by OUD and the fear of dope sickness that you have to make a connection with them first. And maybe that's clean needles and they're using safe. Maybe eventually that's treatment, but it should be up to them when they're ready and what kind of treatment they want. So the largest group of opioid users, as 40%, is people who say they don't want to stop using drugs and they don't want treatment. And how to reach them? Why don't they want treatment? A lot of them don't want treatment because they've been stigmatized anytime they've tried to get it. One of Lawson's best friends had end-stage endocarditis. That's an IV-related infection of a heart valve. And she chose to stay home and die alone rather than go to the hospital where she had been the week before and she'd been treated like dirt. She was 27 years old. Stigma is what's killing people. Stigma is at the heart of all of this. So there are a lot of ongoing political battles about needle exchange, and I take them on in the book. I spent a lot of time in Charleston, West Virginia, where they have the most concerning HIV outbreak in the nation, and the state legislature just severely restricted needle exchange, really to the point of outlawing it. And you go, what? How can that be? And it's just a big political wicket there. An hour away in Huntington, they figured out an end run, and they've got way lower overdose deaths and disease rates. I will just say as a PS on the needle exchange in Roanoke, something I'm going to tell you about later, eventually got the law changed so the police chiefs don't have to sign off on it. The first needle exchange in the whole state opened in Wise, Virginia, because of a forward-thinking health department director named Dr. Sue Cantrell, who was beloved in the community, went to church with everybody, knew the police officers. They did not want her to do this. And she said, y'all, nothing else is working. We have to try this. And because they respected her, they did it. So this is one of my favorite people in the book. The book begins in a McDonald's parking lot next to a dumpster. It's all smelly. And there's this nurse practitioner named Tim. Well, I'm jumping ahead. Let me get to Tim next. First, I want to tell you about Tim's boss, Michelle. Michelle and her wife, Karen, run the nation's only queer, biracial, faith-based harm reduction group in the nation. How's that for niche? And they do it in Hickory, North Carolina. And I'm like, when I heard that, I was like, if she can figure out how to navigate the minefield that is the politics of Hickory, North Carolina, like the world needs to know about Michelle Mathis, right? Especially as this money's coming down. And so that's her tattoo, which is Latin for do shit, don't talk about it. So she and her wife, Karen, started out before needle exchange was legal in the furniture belt, the former furniture belt of Western North Carolina, posing as a food pantry. They delivered food out of the back of their pickup truck, and they noticed that about half the people that came were drug users, IV drug users. So they said, oh, we've got to pivot. They started passing out needles, covertly tucking them into boxes of Nature's granola bars, Nature's Valley granola bars. And they put a piece of tape on it to indicate which ones had the needles in it and weren't just granola bars. And they put their business card in it. And the business card said Olive Branch Ministry and the phone number. And that was it. So that if a relative found the card, they'd go, oh, how nice. They're going to church. And when I first met Michelle, I was on this panel. It was in Christiansburg. It was healthcare people talking about addiction. She was on a harm reduction panel, and I was the last speaker of the day, and I got there early, and I heard her say something I've never heard a harm reduction person said. Everybody says we have to meet the drug user where they are. That's like kind of the theme of harm reduction. Michelle was saying we have to meet the other side where they are too. We have to meet the NIMBYs, the naysayers, the caves, which is short for Citizens Against Virtually Everything. And I had never heard anybody say that. And that's why she's been so successful, because by the time needle exchange was approved in North Carolina, she already knew the DA in the communities where she worked. She already knew the cops, and they trusted her. They liked her. I mean, that's amazing. And so the first time I went down to meet her, she had been called over to Surrey County, which is the home of Mount Airy, which is the home of Mayberry from the Andy Griffith Show, right? At the time, they had the second highest overdose rate in the nation. And so their new opioid response director had, after surveying the county, had realized that a lot of the reason they actually had BUP slots available, MAT slots available, but people couldn't get to the clinic because they lived out in the country. It's very rural. So they got a group of well-meaning church folks together to, you only use your church bus on Sunday. We'll take people to treatment. It was great. They had like 16 churches show up. So I was going to meet Michelle there because she was going to give a pep talk, blah, blah, blah. She's like the expert from 3 counties over. And I didn't even think I was going to write about Surrey County. But this meeting got hijacked about 10 minutes in by the Kiwanis Club president, who stood up and said, I think when they relapse, we should let them die and take their organs. Yeah. And Michelle stood up and said, y'all, do you know that song, They Will Know We Are Christians by Our Love? I am not feeling the love in this room. She said, have you thought of taking your neighbors a casserole? One lady was complaining about drug users living next door. Have you thought about taking them a casserole? Drug users sometimes forget to eat. Like a casserole? There was a lot of work to be done in Surrey County. But when I first met Michelle, she by that point, now that it's legal in North Carolina, she had expanded to 3 needle exchanges in the western part of the state. She has roving peers, mobile peers. They go to under the bridge encampments. They meet people by appointment, via text in their driveway or at a grocery store parking lot. And the first time I went, I was like, yeah, are you going to talk about getting them into treatment? And this was Jessica. She's in the photo at the right. She first met Michelle, by the way, in shackles in jail. So she's an amazing peer recovery specialist in recovery herself. And she's like, no, you don't push it on him. And, so then I was like, oh, I have blind spots about this too. But when I first met Michelle, her goal was, and this is a great thing about writing a book, because you can see change happen over time. And I find that really instructive, especially with this litigation money, like what works, what doesn't work, what are the hurdles that you're going to have to jump politically, et cetera. So she's like, we're on the verge of offering low barrier treatment. And that is also called low threshold. And what it is that she was going to start offering people actual evidence-based treatment, MAT, if she had to go to their homeless encampment to give the prescription, call it into Walgreens. And the guy who was going to do it is in this photo. His name's Tim Nolan. The book starts out in a McDonald's parking lot in Hickory with Tim meeting a new person who has come into the needle exchange, and they do the questions and all that, and he's ready to get on buprenorphine for the first time, prescribed buprenorphine. And so he meets him at McDonald's, and he shows up late. He's high. It's the height of COVID. He's got a broken face mask dangling from one ear. And he says, I'm going to die if I don't get off this. He had just lost his job, drug-related fight at work. And Tim says, well, let's get you some help then. And he interviews him and all this. And the next morning, he's going to call in his discount, which he's prearranged through the federally qualified health center where he works during the day. Tim's going to be able to go get his discount buprenorphine. But this is what he wants him to know. And this is why I started the book with this scene. He says, 1, you can get better. Most Americans think you can't. They've written you off. You think you can't. And 2, and this is key, don't disappear. So that means, like, I'm going to go to you where you are, even if you relapse in the next week, even while you're taking this medicine. If you can't make it because your car won't start, which often happens, then text me and I'll come to you. We'll meet at the Burger King or wherever. And so Tim had begun doing needle exchange for Michelle and Karen for Olive Branch, and giving folks needles in truck stop parking lots and whatnot. And he noticed that people were pretty sick, and a lot of them had hepatitis C, and he started testing them. And then there was a cure for hepatitis C, and he figured out how to get a discount treatment for their hep. And they felt better. And they're like, wow, that's cool. This guy's a miracle worker. And then they're like, well, hey, I have a lot of friends that probably have this too. Would you come out to my house? So thus begins, and Tim is, he was raised by, I'm going to mess this up. He's a devotee of liberation theology, raised by Jesuits. So he's doing this not because he's in recovery. He's doing this because this is his jam. He never gets tired. I don't know how he does it. So, and his jam is really when other folks start hosting hepatitis C testing pizza parties in their house. And Tim shows up with a full lab and just tests everybody there. And then he'll take them back in the room and give them the results. And then he'll start getting them treated. And this is the 40% that don't want to come to your clinic during the day because they don't have access to it. North Carolina is a non-Medicaid expansion state. They can't afford it. Or they've been treated poorly before in a healthcare setting. So, I mean, Tim is amazing. Here he is signing up somebody. This guy told us he had just overdosed 2 days before for the low barrier program. But you can't scale a Tim Nolan. That's why we need real leadership with this issue. and why we need to bathe the afflicted in harm reduction until we have real systems in place. I see them as the glue between this necessary stepping stone, because we have no way of reaching this 40%, which is the largest group. So Tim wanted me to come down after a few visits. He wanted me to come down to the clinic where he works during the day. It's a federally qualified health center, which means it's federally funded. Doesn't matter if you have Medicaid or not. It's a sliding fee scale. And he wanted me to come down to meet this peer in particular. Her name's Nicole. She's been in recovery. I'll tell your story in just a minute. Because he says, when I say she runs the clinic, she runs this clinic. She's a peer support person, and by choice, she runs the front desk. And that's another big key to going to people where they are. So I'm going to just read you a little part of the book. In recovery for 7 years, Nicole has a sixth sense for what to say to broken down people approaching her front desk counter for the first time. She gives new patients her direct phone number. Anybody know any doctor that does that? Well, Tim, that's about it. She pulls the tearful ones aside and convinces them to be honest with their providers. When 36-year-old Julie Steen first approached the clinic counter wearing an oversized pink t-shirt, Nicole noticed her hangdog look and gently asked, "What are you here for today, honey?" And Julie could only whisper, "It's awful." "I'm in recovery," Nicole offered cheerfully. "I'm an IV drug user," Julie said. "I don't work." "I'm in recovery myself," Nicole repeated. "And we can put you on a sliding fee scale." And Julie said, "But I'm homeless. I live in a tent." She was whispering, "My children are in another home." And Nicole said, "We want to see you." In the 4 hours I watched her man the front desk, she calmed a psychotic patient who couldn't stop pacing. She counseled an elderly man with dementia who'd just been discharged from the hospital and didn't remember how he'd gotten there. Between patients, she opened a new box of COVID vaccines, and after a pharma sales rep dropped off lunch from Olive Garden for the staff, Nicole distributed the leftovers to patients in the waiting room. On principle, Tim refuses to eat the pharma unfunded freebies, a fact that other staffers find weirdly hippie-ish. So I don't have a picture here of Julia, but that's my notebook on the front counter, and I just stood there for a few hours. And what I do when I'm reporting is I go get stories, and then I call experts and see what's happening elsewhere, and then I get excited and I tell them what I'm seeing. And I was telling this public health professor in West Virginia about Nicole, and she had just participated in the study. And they looked at the behaviors of 500 people with SUD who managed to stay in treatment. And as an aside, the professional most key to a person's initiation of recovery wasn't their doctor or even their nurse. It was the attitude of the person running the front desk. I was like, damn, Nicole knew that. So I heard about another young phenom named Jenny Atwood. Love it. Jenny Atwood, love it. She lost her brother, Christopher Atwood. She's from Fairfax County, to an overdose in 2013. And she said, he died because I didn't have Narcan. Why doesn't everyone have Narcan in their house? Which is a really good question. And so she started this nonprofit that began with giving out Narcan and then led to a peer support group and a post-overdose response, and needle exchange. And then she found a willing collaborator in a sheriff of all people. That's her third from the left, Stacy Kincaid. She's been a sheriff of Fairfax County for 13 years. It's the only detention center she's ever worked there. She worked there her whole career, so she had buy-in. And Ginny went to her with this idea of locating her peers in the detention center. Now, all of her peers have felony records, every single one of them. And now the deputies are letting them come in and out of the jail at will. So some of those deputies had to be let go. and she fired their asses. She got the CSB, the Community Service Board, to co-locate their counselors in the jail. So Ginny's peers are coming in and out, counseling folks. She has her medical staff doing buprenorphine in the jail. There are two that I know of. One of them is Chesterfield County, which is where the sheriff studied that a lot, and I think also went to somewhere in Texas. There are not a lot of them. I gave a version of this talk a couple years ago to all the sheriffs in Indiana, and I told them some of these stories, and not one person clapped at the end. I mean, and they had guns. I'm just saying. So the most important thing about this, and we should all know this if we have loved ones, that when a person gets out of jail, that moment, they are 29 times more likely to overdose and die because they're considered opioid naive. So, and then, fentanyl is just through the roof. So that is a really dangerous moment for somebody. And at Fairfax, when somebody gets out of jail, they get Narcan, they get a continuation of their buprenorphine, and they get one of Ginny's peers picking them up at that moment of release and taking them to sober living or wherever they've prearranged to stay. And I can't tell you how cutting edge that is. It's almost happening nowhere. And, just this idea that the sheriff who used her social capital for good, like she knows she's in a blue county, people are probably a little bit more likely to do it. But think about Dr. Cantrell and Wise. Like, she was able to get a needle exchange there. This is kind of equivalent. They used their social capital. This is West Virginia. I've talked about it a little bit, but this is people say, wasn't this book really hard to write? And in general, I say, no, it's hopeful because I'm telling people about these amazing people that I want them to know about. And one of those amazing people is Brooke Parker. She's a peer support specialist. She's a Ryan White worker in West Virginia at that peak moment of this HIV spike. And her job is to test people for HIV, most of them living unhoused, many of them doing sex work, and then get them into treatment if they test positive. But there's a huge war on people who use drugs in Charleston, and the police are constantly raiding their homeless encampments. And while we were driving around one very hot August day about a year ago, we were looking for one particular person. And we go to this encampment next to the river, and there's this man in a wheelchair. I cropped him out so you couldn't see his face, but his legs were just weeping sores all over them, and he was dope sick. And Brooke said, honey, and she knew him. She met him before. She said, honey, you got to get to the hospital. He's like, I'm not going back to the hospital. I went last week. They kept me for 18 hours. They treated me like shit, and they let me go. They didn't do anything for me. So she did what she could. She sat at his feet in a dirty, grassy area by this riverbank, and she ripped off the little packets of antibiotic ointment, put gloves on, and put this ointment on his legs. He had been picking maggots out of his feet earlier in the day. He was crying because it really hurt. And at that moment, a police officer came up and put an eviction notice on the camp. And there's this scene, and I'll never forget it if I live to be 100. This woman walks up. She's a sex worker. She lives in the same encampment. And she gives him a bottle of Pepsi. And she says, that triple antibiotic ointment ain't going to cut it, honey. And she says, I used to be an LPN. And then I got married. And hence, and I'll just never forget it, she bowed like she was an actress. She said, and hence, a homeless hooker. And Brooke said when we got back in the car, this is what she tries to tell herself about every person that she's interacting with. They used to have kids. They used to have a home. They had a job. She was an LPN. And this work is so stressful for these folks that are doing this. I mean, I really think it's the Lord's work. And Brooke told me a few months later she was thinking about returning to use. Several peers that I followed did relapse during the pandemic. And that's why we need to scale up their work to a scale that matches the crisis. Just briefly, about a fourth of the book deals with the justice part of the subhead, deals with the effort to hold Purdue Pharma's feet to the fire. Somebody interviewed me the other day when they're like, well, they paid. No, they haven't paid. They wrangled their way into bankruptcy court in White Plains, New York, which you go, oh, are they based in White Plains, New York? No, they're based in Stamford, Connecticut. But White Plains, New York has one bankruptcy judge who favors, this is super wonky, and they want you to get lost in the wonky weeds, who favors non-consensual third-party releases, which means that the Sackler family owners of Purdue get the benefits of bankruptcy without actually being bankrupt. Does that sound like billionaire justice? Because that's what it is. And an appellate judge said, no, you, Judge Robert Drain, don't have a right to tell Ed Bish and Alexis Plouffe, these are activist parents that I follow that are trying to get the victims' voices heard in this very untransparent case. You don't have a right, the judge doesn't have a right to tell Ed and Alexis they can't sue the Sacklers. And so it's currently on appeal. The settlement's up to $6 billion. In theory, if it gets approved, they'll give up the company. But they made $13 billion or more, and a lot of that socked away in offshore accounts. So we have a lot. We need bankruptcy reform. We need, to stop the revolving door. There's so many things that I sort of end that story with this idea that what's going to keep another ambitious millionaire who wants to be a billionaire from inventing a drug that maybe is going to kill people, maybe he's going to start another wave of addiction and get off with a parking ticket. It's not a parking ticket, but it's not even the majority of their wealth. These guys are more heroes. Alexis runs a harm reduction group out of Binghamton, New York. Ed, you might remember from episode 8 of Dope Sick, he testifies at the hearing in Abington in 2007. He lost his only son, Eddie, in 2001. The first time he heard the word OxyContin, his son was dead from it. And, I've probably interviewed hundreds, 300, 400 people since I started writing about this in 2012. The first expert I ever interviewed was this guy named Dr. Andrew Kolodny. He's a addiction doctor out of Columbia now. And I was talking to him the other day. I was fact-checking an op-ed I had written for the New York Times. And I had something really specific. And I hadn't talked to Andrew in a couple of years. He was a consultant on the show, but he mainly talked to Danny, our showrunner. So I'm always happy to talk to him. He always makes me he read the piece and gave me some thoughts. And at the end, I ask, I always say, what did I forget to ask, And then I'll say, well, is there anybody else you think I should talk to about this very specific thing? And he goes, well, you know who has their finger on the pulse of the epidemic better than anyone in America? Ed Bish. I'm like, I've already talked to him twice today. We talk every day. He's hilarious. He will never rest until there's justice for the Sacklers. Ever. He's incredible. That was a story about a bureaucrat in Mount Airy who was at that meeting where they said, let them die and take their organs. He's a DEA agent and a former Marine. The Marine Corps motto is improvise, overcome, adapt. And he figured out a way to make that town open its mind and change its hearts. And I know we're running out of time, but a lot of the book deals with this guy. And I was kind of skeptical of him first. See that whiteboard? He's got it all over his office. And at the beginning, he thought he could whiteboard this issue into recovery. But then he ran into all these barriers. He got funding for a drug court. The judges didn't want to do it. His volunteer network didn't didn't go on. So he got a grant. I mean, he's done all these amazing things. And he now has this team of 12 people. And they are so poised to be able to spend that money correctly when it comes down. Most of them are peers. They're out doing mobile work. They respond to every overdose in the county. And one of my favorite quotes was Marcus, because, Mount Airy didn't want to deal with it at first because their whole marketing thing is based on this idea that we are wholesome Mayberry. And Mark said to me at one, and he wanted to quit his job like every day. In fact, every morning when he left for work, his wife would go, "Bye, stupid." Because he came out of retirement to take this job. I mean, he didn't need the money. And he goes, "You know what? I counted." And I forget what the exact numbers were. It's right in the book. He goes, "There were 200 episodes of Andy Griffith, and Otis the Drunk was in 36 episodes. And not one time did the sheriff ever say, or anybody ever go, 'Otis, you need some help. Let's take you over to Mount Pilot and get you some help.'" So I'll go to questions in just a minute. I just want to kind of wrap up. Here's what I think Tess would agree with these kind of recommendations. We need on-demand access for MAT. So similar to what Congress did with HIV/AIDS in the 80s, they created the Ryan White CARES Act so that people could get treatment on demand for free. And it was huge. It saved, like in the first year, millions of lives. We can do this. Well, we had an event last night, and Nikki was in Roanoke, and she said, if we wanted to, we could get overdoses to zero. We know how to fix this. Harm reduction should come first. We need to meet both sides where they are. Call it a pilot. I haven't told you about Call It a Pilot, but that's a judge in rural Tennessee, and he was totally anti-MAT in his court. And then he adopted a baby with NAS, and he decided to do like independent research. That's an idea. Independent research. And he got it. And he met this doctor named Steve Lloyd. The Michael Keaton character in the show is based on the story of Steve Lloyd. And they started collaborating. And they're now in 5 different counties. And they have reduced overdose deaths by 50%. And Dr. Lloyd makes the treatment decision. A lot of effort on his part. And we just need to clone him is what we need to do. He's amazing. He's now in charge of how the money's going to be spent in the whole state of Tennessee. That's the best thing I've heard about Tennessee in forever. But he says, call it a pilot. Okay, I'm just going to skip right ahead to women get shit done. I'm just saying, women are doing this work. A lot of them sisters and mothers of the dead. I was talking in Binghamton, New York last weekend for Alexis's group. This woman was sitting in the back, and she had a question about drug treatment. And then she told this story. She said it was about 2012, the heroin overdoses were really spiking, and she was a nurse administrator in her hospital. And she kept saying, "We need to do MAT in the hospital. We need to do MAT in the hospital." She had her own son who was struggling. 2014, he lost his battle and he died. And so then she went back few years later, and she's like, "I'm sick of this. They're not doing anything." So every meeting she went to, she held her watch up, and she said, 10 seconds just passed. Someone else just died. 10 seconds just passed. Somebody else died. And so on. And now she runs the hospital's MAT clinic. Women should get shit done. So whenever I speak, I like to just remind people that if you know judges, doctors, probation officers, use your social capital for good. Tell them about the stories of these folks. You could even give them this book if you want. We need stronger leadership at all levels. And at the end of the book, I just take my journalist hat off because my friend Robert Geip told me to. Does anybody know Robert Geip? He's a Kentucky novelist. He's like my Appalachian sensei. He reads, he gives advice. I do whatever he tells me to do because it always goes well when I do. And he said, dude, you have written 2 books about the opioid crisis. Quit telling me what you're seeing out there and tell me what you think. So in the epilogue, I take my journalist hat off. And as my publisher, somebody at my publishing house said, oh, Beth is in the room in the epilogue. And I just go for it. I've got a lot of policy recommendations. I'm pissed off. I'm sad, but I'm also hopeful too. And the answer is really going to people where they are. And it's really communities. At the beginning, I was frustrated because I thought, well, if the federal government just waved a magic wand, and then somebody took me aside and said, healthcare is run at the local and state level. It's not going to work that way. There's a lot of things the federal government could do. They could put a lot more effort. They spend millions of dollars every year on graduate medical education for future doctors, many of whom come out of graduate medical school, don't know how to recognize or treat addiction. I had dinner after my event last night with 2 young doctors who went to Harvard Medical School, and then they did the residency at Brigham Women's. And last week, they're married, they sat through a 9-hour board certification test. They're boards, they call them their boards. I guess that was for internal medicine. That's the kind of doctorate. And by the way, they're going to they're going to Montgomery, Alabama to help Brian Stevenson of the Equal Justice Initiative set up a health clinic for people getting out of prison and jail. I mean, that is badass. So these are the 2 smartest young people I know, and they give me such hope. But they had just taken their medical boards. I said, how many questions on that 9-hour test? 1 question about addiction. 1 question in a 9-hour test. And it was multiple choice. And she said, well, 2 of them were just ridiculous. Like, you didn't even look at those. And the other was if somebody comes into the hospital with an overdose. It was, one of the choices was give them Narcan. The other was buprenorphine. That's a choice. She said, the answer is Narcan, because you can't get better if you're dead. Why is there only 1 choice? Why is there only 1 effing question on that 9-hour test? So I'll leave you with acta non verba, and I'm happy to take your questions now. Thank you so much. I think we have 2 microphones. Do you want to go, sir? Do you want to go to the microphone, or it's right next to you to the right?
My compliments for your literary talents.
Thank you.
With the tsunami of fentanyl from an American perspective, it appears to me that Goliath is well and alive and potentially impacting our nation. My question is, what do you think is our modern day David? Thank you.
The Slayer, you mean?
Yes.
Uh,
What are we doing collectively in your assessment, or what we need to do to deal with the current overwhelming evidence of?
I mean, this is everything I know. This is all my heart. This is all my skill right here. This is harm reduction. This is treatment. This is doctors getting their asses in gear. This is going to people where they are without judgment, with love. Take them a casserole. This is changing the narrative that people can't get better to this is a treatable condition. And if we really wanted to, we could reduce our overdoses to 0. I had never heard that said before until last night. And I was like, she's kind of right. She's always right. But we really need leadership. And these grassroots folks are working at the ragged edge of capacity, and they need help. And we need to scale up what they're doing to a level that matches the scale of the crisis. Thank you.
Yes, hi. Could you talk a little bit about the Department of Defense policies, if you know anything there? Because when I was in service many years ago, their policies were quite punitive about drug use, treatment, there wasn't treatment, but Article 15 was their treatment, their way of treating drug use. But
Yeah.
I'm wondering if now, if there's more enlightenment and more proactive, positive policies in the military bases.
Mm. I, I don't actually know. I mainly dealt with civilian population. Mr. Willis, the guy at the end, would probably be able to answer that question if he was here. He does point out, and I do a whole chapter on the war on drugs, beginning with the Harrison Narcotics Act in 1914, and then Nixon, Just Say No. We have been here before in the 70s when veterans were coming back from Vietnam addicted to heroin. And President Nixon, to garner political points, hired this crusty psychiatrist. And when I say he's crusty, this dude is really crusty. And in a week, he claims it took him 6 or 7 days, designed a nationwide system of methadone clinics that veterans could go to, get on methadone, get help with housing and social supports. It was free. You didn't have to have an appointment. And that's what I'm saying we need now. But back then, this is before the drug war really took off, our national spending priorities, where we spent 30% of our addiction mental health money on incarceration and 70 on treatment. Now we spend 70 on incarceration and 30 on treatment. And Mr. Willis just said this last week. I did the first event in North Carolina. He said, it's got to be even. Sure, we've got to have people at the border trying to intercede with fentanyl, but until we deal with the supply, we've been dealing with until we deal with the demand, it can't just be a supply issue. I know that doesn't quite answer your question, but yes.
Right.
One more
One
question.
more? All right, I'll try to make it good.
Okay, awesome.
I was curious for your reaction yesterday to Governor Newsom in California vetoing the safe injection site bill, and kind of what that means, not just California, but more for harm reduction advocacy in the future in general.
I mean, I think it's terrible. Again, it's a counterintuitive thing. We have 2 safe consumption sites in America, and they're both in New York City. The one in Philly has been, they've been trying forever to get that. And there's a huge NIMBY outcry about that. In Kensington, it's just awful in Kensington. And I am for anything that gets people connected to systems of care. How are we going to reach that 40%? Because those are the people who are dying. And if it's a needle exchange, if it's a safe consumption. When I was finishing Dope Sick, I went up to Boston, and they have this Boston Healthcare for the Homeless. And they had, I forget what you call it. It wasn't quite a safe consumption, but people could sort of like fall in there after they had used, and they would be medically monitored. And, and then they would make connections to care. Some of them, not all of them. And I just think any way that we can make a connection, that's what we have to do. That's what we are called here to do, to help each other. Thank you.
Thank you.
I know we probably have lots more questions, but I want to give you an opportunity to chat with Beth at the book signing table, and that's where she's headed right now. So please make your way out there. And thank you for coming tonight. And we look forward to seeing you at our next Weinstein lecture in September. Thank you so much.